lean back too hard. You will.
Please find your seat. The program will begin shortly. Please take your seats. The program will begin momentarily. The program is about to begin.
Good afternoon. Thanks for being with us today and joining us for a very important conversation about the future of rural healthcare in America and what we and what you can do to improve it. My name is Jason Stevens. I have the privilege of working for Wellstar Health System, serving as the leader of our external affairs department. You might not have heard of Wellstar. Let me tell you a little bit about it so you can have the context for our conversation today. We're a proud not-for-profit integrated healthcare system, and every dollar of revenue that we have that exceeds our expenses goes right back into delivering care to people regardless of their ability to pay. And as a matter of fact, each year we've given away in the last 5 years over $1.2 billion in care to un- and underinsured patients throughout Georgia and South Carolina. We have 34,000 employees and 400 sites of care across Georgia and South Carolina. We are deeply committed to rural health, more committed than any health system in the Southeast to the future of rural health care. And I'm really proud to have with me today a panel of industry experts that are part of Wellstar or work in partnership with Wellstar to talk about rural health and let this be a conversation we have together. I'm going to start with a question for a good friend and colleague of mine, Dr. Richard Freeman, and I'm going to ask each panelist just to give one sentence introduction about them when they answer a question. So we'll dispense some formal interviews and go right to the meat of the subject. But Dr. Freeman, why don't you tell us who you are and why there is such a divide between rural America and urban and ex-urban America in healthcare?
Sure. Thank you, Jason. Good afternoon. I'm Richard Freeman. I'm a thoracic surgeon by training, and I serve as the chief physician executive for Wellstar Health. There's always been some disparity between rural and urban healthcare, but that has increased in recent years. You start to see things like large differences in perinatal mortality between urban and rural, and that's just one example. It's multifactorial. We know that about 20% of people live in a rural environment. About 5% of medical practitioners practice in a rural environment. So right away, you've got a disparity. We've all been talking about a physician, clinician, APP, fill in the blank, shortage in healthcare workers for 20 years. That has finally arrived. And to the point that you have trouble now recruiting those kind of people to urban environments. We know it's more difficult. I know personally it's more difficult to recruit to rural environments. We pay a premium for anybody we recruit to a rural environment. And we have difficulty finding those people. So it's multifactorial, but it's really exponentially ramping up because of the provider shortage that we're starting to see, Jason.
And before we go to Michael Purvis on the end, I want to come to Dr. Matt Lyon. And Dr. Lyon, tell us, one, who you are, and two, what the disparity difference, how it's measured between rural and urban healthcare in America.
Matt Lyon, I get to work for Wellstar to connect Wellstar expertise to our rural hospital partners. So really awesome job. And we do that through digital health. But if you look at rural Georgia, the disparity between urban healthcare and rural healthcare is very stark. We have in Georgia some of the worst healthcare outcomes, particularly for moms and babies, but also our older citizens. And if you look in Atlanta and some of our metropolitan areas, you have some of the best. And so what we talk about a lot of times is the two Georgias, where you have the best of the best, and then you have people that are left behind. And so with digital health, we look to ease that disparity and bring everybody up to the same level of excellent health care.
Dr. Lyon, what is the rural mortality penalty? Is that right?
Yeah, and so if you just look at people that live in an urban environment, I mean, traditionally you would have thought that they would have had better health care. I mean, they're closer to nature, they have better agriculture and farm food and, cleaner air, but in reality, the disparity is high, that if you live in a rural county, that you're going to have a worse life expectancy, you're going to have higher mortality from cancer, diabetes, cardiovascular, stroke, and we all work and live in the stroke belt, so that difference is very stark. And so just because you live in a rural county, you're already starting out with a healthcare disparity. So,
Michael Purvis, I want you to tell us who you are and what role that you have the privilege of playing in rural healthcare.
Thank you, Jason. Good afternoon. My name is Michael Purvis. I'm the CEO at Dodge County Hospital in Eastman, Georgia. Dodge County is in the center of Georgia, so if you took a dart and threw it at the center of the state, that's where Dodge County sits. I have the privilege to work with some pretty incredible folks. We're an independent hospital authority, county hospital, and we live this 24/7. What we've been able to do with the digital care network has been phenomenal.
I'm going to stop you there, and because we used a term that I want to make sure everyone understands. You use the hospital authority hospital, and then you also said you're independent. So the hospital that you're CEO of is not technically part of Wellstar Health System. So Wellstar operates 11, soon to be 13 hospitals that we own and operate, but yours is not one of ours.
So I think the biggest takeaway of the digital care network is that you don't have to be acquired and you don't have to be owned by a larger health system to work with them.
So what is the digital care network? You've used that term a couple of times, and I'm sure the audience is curious. What is it? We sometimes call it the DCN, the Wellstar Digital Care Network. Tell us what the DCN is and what it means to Dodge County Hospital.
So we took the work of Matt Lyon and the folks at Augusta University Medical Center, and we embedded critical care through telemedicine into our ER, our inpatient, and ICU care settings. And it's part of our core patient care offering now. And we've seen the human connection through telemedicine. We have reduced transfers by almost 30%, and we have returned 2 rural hospitals that I've had the privilege to work with to profitability and sustainability is what we're all talking about today.
So let's bring this down to an example, and I'm going to use an audience member. So you're Corey, is that right? We didn't rehearse this, okay? And let's say that Corey is a patient who lives in Eastman, Georgia, in Dodge County, Georgia, rural Georgia. And Corey is having chest pains and calls 911 and is transported to the nearest emergency department, which in this instance would be your hospital, right? So tell us about Corey's experience without the Wellstar Digital Care Network. Let's go back to 2018, before the DCN was in place at Dodge County Hospital. Tell the audience what Corey's experience and triage in the emergency department would be like.
She's going to get swift, life-sustaining care. We're going to stabilize her as quickly as we can, and then we're going to shift towards transferring outside of Dodge County into a larger hospital that could potentially do heart surgery or heart cath, some advanced procedures to help keep her sustained and well in the future.
And how far away would that have meant that Corey would need to be transported, and how would she be transported? She can't drive in the condition. I mean, you can drive, but you wouldn't drive.
So most of our larger hospitals are very busy. A lot of them go on diversion from time to time. So
What's diversion?
Diversion means that that larger hospital has reached capacity for that condition. In this instance, it would be cardiology. It would be potential heart attack or whatever you want to come up with as an example.
About how far away would it be, probably for her to transport to a...
So on a good day, we're talking about 60 miles, but on an average day, it's like 200 to 300 miles.
Now, Corey, you have a family and friends that live with you in Eastman, Georgia. So what would the impact be on them for you being transferred to 2 hours away? Yeah, uncomfortable and inconvenient, right?
Yes. And a good example is that, we don't see them as patients. These are our neighbors. These are our family members. Yes. These are people we go to church with. And we want to provide the very best care at the least cost possible.
And you can imagine now you've got Corey and no support system. They've been separated.
Yeah.
So a lot of times we'll do like a GoFundMe, or we'll take up money for those families to be able to stay in those larger communities, and sometimes they're there for weeks, oftentimes months. It just depends on the condition.
So a few minutes ago, I said, let's pretend that was 2018, right? So now let's go forward a year to 2019, and I'm going to throw to Dr. Lyon, who was the founder of the Digital Care Network. And so, Dr. Lyon, you've heard what Michael Purvis described would have been the patient's experience without telehealth intervening in her. So tell us about what the Wellstar Digital Care Network did, and then we can come back and run the fact pattern after the advent of the Digital Care Network.
Yeah, the Digital Care Network is about connecting specialists to those rural Georgia, in this case, practitioners. In rural communities, you may be a practitioner of one. You may be a practitioner of two, but you really don't have a lot of partners out there to help you navigate a patient's care. You really don't have that support system. And so what we do is we connect those specialists into those rural county hospitals at that point. So 24 hours a day, somebody's available. They're going to be there at 2 o'clock in the morning, same as at 2 o'clock in the afternoon. And the interesting thing, Jason, is that most patients don't need to be transferred. Many times we are transferring because of fear of disease. And so what we do is we help allay that fear. And we say we try and change it from transfer for uncertainty to keep with confidence. So if you've got somebody in the boat with you, they're rowing along with you, they're not going to desert you. Even if you keep that patient in the rural hospital, if something goes wrong at 2 o'clock in the morning, they're still there. But they help be that support system. And so while we're not really miracle workers, a lot of times we're just present. And by being present, we have changed the patients we see. Typically, before we started, Jason, it was about 70% of the patients we see now would have been transferred. Now about 70% of those patients stay. So we're still transferring for a higher level of care sometimes, but most people are able to stay in the rural county hospital.
And just to be clear, this is on a telehealth platform.
Yes, sir.
Right. So the emergency room physician calls up and says, I need a cardiologist.
So let's bring it back to care, to Corey, and personalize it.
Yes.
So roll it forward a year, 2019, same symptoms, chest pain, go to Dodge County Hospital that's now a member of the Digital Care Network. And Dr. Lyon, tell us what Corey's triage in the emergency department, how it would be different now.
Well, we partner with our rural providers, and so we don't take over the care, we're a consultant. But it starts with the same way Michael said. So she comes in, she gets triage, she gets immediate life-threatening care, she gets labs, she gets imaging, all of those things. But let's just say a little bit of her labs are a little abnormal or her systems were persistent. Instead of immediately going to transfer, bring that specialist in. That specialist can look at those labs, can look at those values, talk to the patient, talk to the treating provider, and come up with a plan that would help them stay in that rural hospital. Again, keep with confidence, allay those fears. Say, look, it's a 20% chance that something's going to happen in the middle of the night, but at middle of the night, I'll be right here. At that point, if we need to transfer, you've already established a patient-physician connection, and we will make sure that happens. You're not going to get stuck with that patient. We found a lot of times in the pandemic that patients were unable to transfer. And so because they were unable to transfer, practitioners had to take care of things and people and conditions they didn't really feel comfortable with. We've taken that philosophy now of being able to assist them, and we've brought it post-pandemic. And we've actually seen our use of telehealth and digital platforms go up because we've built the system for that kind of care.
Dr. Freeman, let's talk about quality now. So certainly Corey's experience has been less frictioned in this environment, in this setting. But talk to us about how you measure quality and how there's an assurance that Corey's going to get the same quality care she would as an in-person encounter.
It's a great question. So as opposed to an emergency department physician trying to call around and see if they can get a cardiologist to talk to them, and they're doing it over the phone, this is in real time a digital connection. And so they are talking to the same cardiologist that if you had chest pain in Atlanta and rolled into one of our emergency departments, it's the same cardiologist you would see. It's the same neurologist if you're having a stroke. It's the same fill in the blank. And so the quality is at that level. Not to say that there aren't really good quality physicians in the rural areas. They're just dispersed over a wide area, and they can't take call every night. And so this gives you, as Dr. Lyon said, 24/7, 365, that same level of superior quality.
So we were talking a couple of days ago about a term you just used, they can't take call every night. And you talked about how it is difficult to recruit to rural hospitals and rural communities because of that, what we call call burden. So talk through that with us a little bit about why that call burden is an impediment to being the sole physician in a community.
It's one of the many reasons that makes rural recruitment difficult. People coming out of training are usually coming from an urban environment. They may have significant loan debt. They may have family issues who have special needs. And they also may not want to go to Douglas County and be the only cardiologist, which means they never get a night off unless they leave town. And we know that people don't look for that opportunity today. It's very difficult to recruit people into a practice like that. You have to pay them a lot of money knowing that they're not going to be able to sustain that for 10 or 15 years. And we really don't want them to, right? That's setting them up to burn out and leave. So call burden is a huge issue, and this alleviates that.
And Jason, one other thing, I mean, healthcare now, medical education for healthcare now is really about a team dynamic. And so we're training our physicians now to work in a team. And now you put them in a rural hospital where they do have nurses and respiratory therapists, but they don't have the other specialists around them. And so that is also, leads to that uncertainty. Am I doing the right thing for this patient that's standing right in front of me? Should I get them to a higher level of care? And by being able to bring that specialist in, you really make that practitioner feel more comfortable, which hopefully over time will help people feel more comfortable moving to those rural areas.
And we're talking about this reconnection for the rural hospitals into the larger health system. But what that's done is it's helped us retain our nursing care that we desperately need. And it's also given our physicians the confidence to stand in the trenches and provide this care because they have that backup. I think the beauty of the digital care network is even if Augusta University or Wellstar is on diversion, if we get to that point in time where we have to transfer, the answer is never no. The answer is yes. And most oftentimes, we have trouble getting an ambulance to be able to go 300 miles and still take care of the 911 calls in our county. They'll even come get those patients. That's the beauty of the digital care.
And you used a term there. I want to make sure that we're following you. You used Augusta University and Wellstar. So Dr. Lyon, why don't you talk about the academic component of the digital care network and how students who are learning to become independent physicians are activated through the digital care network.
Absolutely. So education is really important for this. Again, people, doctors are now trained in a healthcare environment, which is really team medicine. And so when you ask them to go to rural environments, one, they have to experience it to see the advantages of living there. But the other thing is they have to experience how they can still be connected and be in a community that helps them provide the best level of care, their ongoing education, all of that. So being able to work in a medical school, Medical College of Georgia, which is at Augusta University, work with Wellstar that has a large, broad, experienced physician group that can tie in through digital means. Our students are able, on the front side of medical education, to provide digital health, see digital health in action to rural communities, and then we send them to rural communities, and then they are the receiver of that. So it helps bridge that knowledge gap, that experience gap, where they can feel comfortable and envision themselves in a rural environment.
Yeah. Dr. Freeman, you were going to say something.
I was just going to say one of the ways you know that this system is working is because the nurses love it,
Yes.
right? They are really the closest person to the patient often, and the network that Dr. Lyons set up allows the nurses to initiate this at times and say, I'm not comfortable, I'm going to call the digital network and get them involved. And I just think that really shows you that it is working and that they rely on it.
Dr. Lyon, you shared a statistic about 5 minutes ago that I want us to not gloss over, and it was the 70-30. And the first time that I heard this several years ago, I had to kind of sit with it and understand it. You said that when the digital care network, before it started, so in 2018, Corey's having chest pain, 70% of the patients like Corey receiving care from rural hospitals in Georgia would have had to be transferred 200 miles to a higher level of care via helicopter or ambulance. And that now the number is reversed.
That's right.
And now it's 30% of the time
That's right.
the patient transfers, and 70% of the time Corey can stay in the county where her family is.
Right, and the interesting part is we've talked a lot about the emergency department, and that is where care initiates. But it's also on the inpatient side. So our program works from triage to discharge in that hospitalization. And so at any point in there, whether it's a nurse or one of the clinicians, they can initiate a consult so that that expertise flows to that patient where they are. The important thing is that by being able to do that and have that confidence, then more people are admitted from the emergency department into that inpatient setting. And once they're there and we're able to participate with that patient on a daily basis and make sure everything's going right, those practitioners over time build confidence in keeping sicker and sicker patients. So it's a really unique dynamic where in rural Georgia, when you have a high transfer rate, let's say 70%, what the community starts thinking of you is a Band-Aid station. I'm going to go there and I'm going to get transferred. And Michael will tell you, a lot of times that means that over time they just bypass your hospital and they just go on and go to there.
Right.
Whereas in this case, we keep more and more patients. Not only does the community feel better and more confidence in their local hospital, which means they get care quicker, they get better care, they get care closer to home, but also they're able to, the clinicians, the nurses, the respiratory therapists, the nurses, the pharmacists, they're able to take care of a sicker cohort of patients over time, which makes them expand their capabilities to take care of even sicker patients. So Michael and I have seen this goalpost move of where we started, and it was, you start with a new hospital and maybe you affect 10% of their transfers, and then maybe you 30%, and then 50%, and finally when you get mature, it's about 70% of the patients we're able to keep and not transfer.
Michael, let's talk about the economic impact that this has had on your community hospital and, in theory, on any rural hospital. Just speak to that. How has this affected the economy in Dodge County, Georgia, and Eastman, Georgia?
So for Dodge County, when I came in, I've been there about a year. And from there, I came from Candler County Hospital, it was in Metter, Georgia.
Candler County Hospital?
Candler County Hospital.
Metter, Georgia.
Metter,
All right.
Georgia. Very small, 4,000.
You're not from New York City.
No, I'm from New York City. You can tell by my accent a little bit.
I'm just helping translate
That's
a little bit.
What accent?
So when I got to Candler County, there was $33,000 in the bank. It was on the brink of closure.
$33,000?
$33,000. And within 18 months, we were hitting what I call more sustainable cash flow in operations, and within 3 years, we were profitable. And when I left after 5 years, we had hardwired so many things through the digital care network with our local physicians, with our advanced practice practitioners, that hospital remains to be viable and sustainable. And so at Dodge County, going there, Dodge and Candler both were part of that initial rollout from the very beginning. And so Dodge was already leveraging the digital care network. Not that I've done anything any different. We've just made the utilization more. And so when I got there, Dodge was losing about $500,000 a year. And it looks like a year and a half later, we should have a profitability of around $1 million.
That's
So
amazing.
that's the beauty of the digital care network.
Yeah.
And it's so important to keep those rural hospitals open.
Yeah, yeah. And the community sense of pride, too. I mean, I can see it in your face. It just, you light up when you talk about it. Well, so we've educated we have a question.
Yeah, I was just curious, who's funding the digital care network? If you're not taking over the patient, who are you billing?
So I'll repeat the question for the audience. So who's funding the digital care network if you're not taking over the patient who's billing? And that's a great question. And so I'll frame the question a little more broadly in this way, as Dr. Lyon, how is this model economically sustainable for the telehealth encounter that we provide to Corey? And Dr. Lyon, let's start with you.
One of the most, my pride point is that when I started coming to rural Georgia and talking to CEOs like Michael, they had a little bit of grant whiplash, I call it. You know, people come in with great ideas and say, I got this grant, I'm going to help you. And they say, really? And then they do an intervention, whatever it is, even what I wanted to do. And when the grant's out, they're out. And so for rural populations, it is worse to give somebody something and then take it away than it is to not have it at all. And so when we went into this, we had sustainability built in from the beginning. We do charge a fee to our rural hospitals, which is self-sustaining because they're able to keep more patients and generate revenue. We also bill the patients for our services. And between those two things, we're able to keep those patients there and also provide this expertise to come in and work with those rural hospitals. Coming from the group we come to, Dr. Freeman will tell you, I have to go recruit people to do this. But working in the practice environment we do, it is really an honor to be able to help people in rural Georgia that you know would not have access to an emergency physician, a cardiologist, a neurologist. They wouldn't have it otherwise. And so me going to one of our specialty physicians and making that proposition is usually a pretty easy job.
And I would say, not a lot of people play the long game in healthcare. I think part of Wellstar's mission, we feel like we would much rather intervene and take care of somebody than have them show up a week later and be very sick, and they're still going to come to us, right? We're still going to take care of them. We're probably not going to get reimbursed for it in certain situations. So for us, it's part of our mission, and we try and make it self-sustaining, but frankly, we pay for some of it, and we do have grants and other things, but we feel like it's part of our mission.
And they're the ones reimbursing the cardiologists and whoever's providing the expertise, because they're not going to, there's goodwill, but then there's.
Yeah, in this example with Corey, Dodge County Hospital pays a monthly fee to the digital care network, and then the payor for Corey, whether it's Medicaid, Medicare, or commercial, Wellstar bills the professional encounter for that cardiology telehealth encounter. And one of the few gifts we got from the pandemic was the advent of enabled billing for telehealth visits. So that was something that we've been able to take and expand into the digital care network environment. Yes?
Can we talk about infrastructure investment at the rural hospital? Who paid for it? How did you fund it? For the telehealth medicine itself?
Yeah, we started with a USDA grant that helped with the initial equipment. We had to do proof of concept. Going forward, sustainability is built in, which includes the equipment and connection costs and those type of things. Currently, we're undergoing rural health transformation grants, so we're working now to bring in even next level technology to make this even a stronger program and bring more hospitals on board with what we're doing.
So hopefully most of you are familiar with that rural health transformation grant. Georgia got just over $200 million in funding for over the timeline of spend. And there are many rural hospitals that are going to be able to tap into the digital care network using those RHTP funds. So it's a really nice story that is going to accomplish exactly what CMS wanted to do. And when is the last time that you heard someone say that? In a way that patients like Corey win and communities like Eastman, Georgia win as well.
If I can tag on to that just for a second, if you think about, the way healthcare works in rural urban, right? It's the urban hospitals that, will say yes. So an academic medical center or tertiary care center is going to say yes to those transfers that Michael was talking about. A lot of times they're 200 or 300 miles away, but they're going to say yes. But if you think about it from a healthcare standpoint, you're taking patients from rural Georgia and you're sending them to probably the most expensive beds. And so through what we're doing in the rural health transformation, we're changing our model more from a hub and spoke, which really pulls people out of rural Georgia, to a hub and hub type model where we're doing intra-rural transfers. We're trying to keep the patient as close to home, even if that's another rural hospital that has capacity and capability and also digital connectivity. So we're able to do a backbone across that patient's care, whether it's in one smaller rural hospital to a larger rural hospital or even up to a tertiary or academic medical center.
And rural hospitals like mine, this reconnectedness that we're talking about taking capability and turning it into capacity, which in turn makes us sustainable in the future.
We got a question here. I saw Deacon's hand first.
Thank you. I'm Deacon Turner from Cherokee Nation of Oklahoma, other end of the Trail of Tears from you guys. And my question is about scalability. I really love this model. Cherokee Nation runs its own healthcare system, which we contracted from IHS a number of years ago. We've got 500,000 citizens, and we're the dominant health provider in a rural area, kind of similar to what you're doing at Wellspring. Wellstar, sorry. Who are your peers? The question I have is, you're serving the Georgia rural hospitals. Who do we turn to? What are the other networks that are out there? Because we've got these same issues. Exactly. Everything you've just laid out is what we have.
Yeah. So I'll give an initial response and look to Dr. Lyon and Dr. Freeman. Unfortunately, there aren't many of us out there. Sanford Health in South Dakota has an equal commitment to rural health that we have. But beyond that, there are not significant players, and we think that this is a gap that needs to be filled, and we're really honored to take a leading part in it. But Dr. Lyon, what would you add?
I would say that, if you look even back at the Aspen report, it talks about that, some of the rural penalty we've been talking about is actually fairly recent, right? And a lot of that has to do with policy. And so when you're talking about how do you provide this kind of service to a broader area of the United States, you start running into some policy issues, whether it's credentialing, cross-border, licensing. Those barriers really do add up. We are scaling. We've scaled even in the last 18 months. We're scaling from about 15 hospitals to about 25 hospitals, about 25% to about 35% of rural Georgia hospitals. So scaling is not a problem, but scaling across borders does lead to challenges.
Yeah. And, we talked about the Rural Health Transformation Grant. That's fairly recent. You've been building this for 6 years. So this has taken time, and hopefully will allow other people to leapfrog and not have to build that 6-year timeline.
A lot of it is thought process. If you think about it, it's more relationships and in systems of care. And if you think about, let's say telestroke, telestroke is a great model, been around for a long time, nationwide standard of care in a rural hospital. But if you think about it, you've got a stroke neurologist on there that says, yes, give that clot-busting drug, but now transfer them to me. Right. Digital health has so much more power to change that paradigm of the patient coming to the specialist coming to the patient. And so once you start understanding that paradigm and getting systems of care in place with, active participants, again, we don't replace those local primary doctors and specialists that are in the rural communities. We partner with them and the CEOs, and we make our goals of care their goals of care. Once you start doing that, you can start seeing how access really can span some of these problems we're talking about.
And just one other note about the transfer issue. So COVID was an interesting phenomenon. We found out we didn't have enough tertiary quaternary care beds in the United States, right? Because of a hopefully once-in-a-lifetime event. But since then, major tertiary quaternary medical centers have been on diversion. They've had 100 people in their emergency department waiting for a bed.
Yes.
We can't and shouldn't take every one of those patients. We want to keep them closer to home because it's the right thing to do and it's better care, but we also can't manage all those patients. If we take all those patients, those medical centers can't do the things that they have to do, transplants, things like that, because they don't have the beds.
I had a quick patient story. I had a patient that was a really good friend of mine. He lived in Sylvania, which is not, it's about equidistance from Candler County where Michael was to Augusta. And he called me up and he said, "Matt, I screwed up." I go, "What's wrong?" He goes, "I got the COVID." I said, "Well, listen," he had all the risk factors for bad outcome. And I said, "Well, listen, our emergency department is quite full." I said, "We can see you in Candler County Hospital." I said, "Please go there." He went there, got seen immediately, was out of the hospital in 2 days with excellent care. That's the power of what we can do.
Lisa, we see you.
A little greedy. I've got two questions. One is that we're seeing more patients not have access to health care with Medicaid under threat and healthcare premiums as they are. And so in terms of a reimbursement model, if we're talking about residents that don't have access to health care, what does that look like for a rural hospital? Two, I'm a pediatric hospitalist. I work in a small community hospital, maternity desert, to the west of us, and 30% of pediatric beds in this country have been decimated because a third of kids are on Medicaid, and Medicaid doesn't reimburse as well. So I'm curious, how does this, I do want to start by saying the work y'all are doing is awesome. But for those two issues, how does this work in terms of maternal care, pediatric care, and the threats to Medicaid?
That's a great question. I think the most exciting piece of information I could share with you that we're working on through transformation is bringing digital telemedicine OB into our ER for all our rural hospitals. Dodge County Hospital had a $2 million loser in the OB practice, and so they had to discontinue OB about 2 years before I got there. That created a challenge in our ER. Now, we've had mamas show up. They want to deliver at Dodge County. They show up in the ER. They learn that we don't do that anymore. But through our connection, we're able to sustain like 24-week-old delivery and get them to that next level of care, and the baby survives. That wouldn't happen before if we didn't have that in place.
And you're also pushing out maternal fetal medicine.
That's correct.
Via the digital network. So, and I don't want to misspeak because our service line leader for OBGYN is in the audience, but the average OB doctor takes care of women and takes them through childbirth, and then there are very complicated situations where maternal fetal medicine physicians do that. Those people are very rare, especially in the rural areas, and that's becoming part of the digital care network.
Yeah, we spent, usually when we tackle problems, we were talking about the Cherokee Nation and all that. I mean, we go and survey our rural hospitals, and you look at Georgia, and it has some of the worst, and some of our counties have some of the worst maternal outcomes. And you go and ask why, and so you do a needs assessment, and if there's not an OB presence in that hospital, a lot of times they're just not prepared, even though it's a requirement for participation in Medicare to be prepared. But they're not really prepared. And so by tying in an OB doctor that is prepared for emergencies with standardized equipment, we're hoping to change that paradigm, aren't we?
Yes, we are.
Blue dress right here. What is your name, ma'am? I think that's blue.
Hi.
It's gold.
My name is Gail. I'm hearing you talk about things that present to hospitals.
Yeah.
Patients know if they have chest pain, if they are having a stroke, they go to the hospital. But I'm curious about outpatient medicine. Somebody with severe rheumatoid arthritis doesn't usually present to the ER. They usually go to their primary care physician. And then there may be a 6-month wait to get in with a rheumatologist. Somebody with hyperthyroidism from Graves' disease, same thing. And these may not be diseases that will kill you immediately, but they have very severe long-term morbidity and mortality if not appropriately treated. And so I'm wondering, my colleague here and I are the only 2 internal medicine docs for an FQHC in western Colorado that takes care of more than 17,000 patients.
Wow.
We work with a great team of family medicine docs and APPs, but we get really sick people coming, and fortunately she and I have taught ourselves a lot about how to manage these diseases, but that's just our little system, and it's not adequate. I'm wondering if you have looked at all at extending this into outpatient medicine, what barriers you might have seen to that, et cetera.
Dr. Freeman, you want to start?
Yeah, I mean, I think it's a great question, and my first question is, how did you both leave town at the same time? But
Yeah.
do they know? We are contemplating how best to do that. We're doing it a little bit one-offish now, but I would love, the next outpatient building that we build, you may have 4 exam rooms for you and 4 for your partner, and then there's a telehealth room. And your patients used to coming to that office, they can come to that office and go in that telehealth exam room and see an endocrinologist. We have 14 rheumatologists in our Atlanta practice. We can get people in, but people don't want to drive 3 hours. So we are looking at that. We're not as mature there as what Dr. Lyon has developed in the ED world, but that's on the list, certainly.
Green. I'm sorry. I meant to come to you first, then we'll go to Green. Your colleague there, also in the blue.
Oh, the other one who left
had
town.
lots of questions. Yeah, well, we live in the valley, so it was easier for us to leave town at the same time. So my name's Sutton. Yeah, and like Gail said, we're internists. I'm also a pediatrician. A question that I had was, obviously if you're relying on specialists at the academic and tertiary centers to do these consults, that's adding to their workload. Certainly they're billing for their services, but I'm curious what you've done with staffing on the consultant side, because certainly, depending on the specialty, it can be hard to staff that as well without burning people out.
Well, the same in reverse, right? So I may have 5 exam rooms and I see 4 normal patients, and then I walk into the telehealth room and I see a consult. So it's not going to be the same value probably, and that's an issue. But you have to make it easy, right? You have to make it easy for the provider to walk in that 5th room and see a telehealth consult, and not have to go to another building or fool with their computer for 30 minutes and it doesn't work. People aren't going to do that. You have to make it easy.
Yeah, we also employed, to great effect, e-consults, as we call them, which is peer-to-peer. Which a lot of y'all know about, but we try and make it concierge. And so how do we do that? Well, we make it as easy as possible for that specialist to participate, as well as that provider in rural Georgia. And so if you can facilitate that and you make it easy, then that knowledge can flow. Sometimes it's just, saying, hey, you're doing the right thing, but we have very specific pathways that make that a little easier to say it's for our practitioners. Just to give you an example, ID is our biggest one, infectious disease. And with that, generally a consult from Michael's orthopedist generally only takes them about 10 minutes. And so because it's very effective for them, they're willing to participate.
And the number one question I get locally from my physician group is, when is the outpatient coming? When will we have access to it? And we are working very hard to bring that through transformation, through our work with the rural transformation funds. And I am so excited to roll that out, because this is something we've talked about in our rural hospitals for years. Like rheumatology, you just about set me up on that one, because it wasn't 2 years ago, I'm calling Dr. Lyon, and I'm like, man, I've had my eyes open to rheumatology, and it's not only affecting my family, but as I look at absenteeism in my nursing groups, that's the number one reason. That is, they suffer from this disease, and they don't have accessible resources to deal with that on a day-to-day basis.
Lady in the green.
Hi, my name's Alana Arnold. I'm a physician, pediatric emergency medicine. So I think some of the colleagues in front were speaking on this. I wanted to hear kind of any initiatives or plans around pediatric care in the rural space. What I found, I'm from Philly, so, very urban area, but there's a lot of, I think from a financial standpoint, people get hung up, but there's a lot of low-hanging fruit in terms of completely unnecessary transfers that are occurring to facilities that are hours and hours away, difficult for the families to get to, and also just revenue leakage. So I wanted to hear in terms of your thoughts on that, in terms of specific pediatric care for critical access in rural places.
Well, we not only do we do emergency, in the emergency department, and on the inpatient side, we also do pediatric emergency. Most of our rural hospitals will not admit, particularly, a kid under 12 to their floor. But as you said, a lot of times it's just being in the emergency department, not doing a CT scan when it's not indicated. We've been working really hard to get our pediatric surgeons involved with that, as well as tying in our pediatric subspecialties. A lot of that ends up being on the outpatient side, which we do have clinics in partnership with our Department of Public Health around our rural communities for pediatrics specifically. But you're right, being able to tie in a pediatric specific emergency provider really does affect that transfer rate, because a lot of times they don't need to be transferred.
We're going to take one more question, and then we are going to, I'm going to ask each panelist to give us a parting thought or something to take away that's action-oriented. I know we didn't get to all the questions. If we don't get to your question, we'll be around, and they'll be the ones to answer, not me. And we'll go to you, ma'am, with your hand up.
Awesome. I feel like I won the lottery. My name's Julie Wernow. I'm a journalist with the podcast Trade-Offs, and I happen to live in rural Georgia.
Wow.
Wow. Where do you live?
I live in Dade County. Yeah, so this is really interesting. I didn't know any of this. My question is really like, we've talked a lot about the outcomes in terms of the change in transfers. What kind of health outcomes data can you share, if any, in terms of how this is helping, with some of these terrible numbers that we have there?
Any thoughts?
It's difficult sometimes to project things out to a population health to come up with a really interesting statistic. What we do know is that the satisfaction of this, of patients being able to get care that they have confidence in their home community, has definitely changed that paradigm of skipping past a hospital. And so we have a lot of numbers where we look at in and out of county care, and we can see that as we start working with the rural hospital, not only do their finances and their ability to give complex care improve, but their community perception. And so the amount of care that's being delivered in county goes up. Why that's important, and again, as Dr. Freeman said, it's the long game, right? What that means is that people are accessing healthcare more frequently at an easier way. That means that there will be less delays in healthcare. People will not have some of the penalties that we talk about deterioration, and then they finally get to where they have access to a specialist, and yet, their heart functions less. This access really does translate into better healthcare, but asking for statistics, it's going to take a little bit more time, because it is hard to change some of what we see in rural Georgia just on the acute care side. And so as we work on that outpatient side together, I think we'll see much, much more publishable data.
And the one thing that you don't think about, so a small rural hospital may run the 911 service.
Yes.
They may have 2 ambulances. If one of them has to go 3 hours each way, you may not get a response if you call 911. So reducing the transfers is really important, not just to keep the hospital doors open, but to give better care to the people who live there.
So we're going to wrap up. And Michael, I'm going to start with you and ask you, what is something you'd want the audience members to take away from this conversation that's action-oriented, things that they could do or parts they could play to take this type of model of care and extend it beyond the walls of Georgia?
Yeah, I think rural hospitals, we don't have a technology issue. We have access to specialty services. That's where the rubber meets the road in our hospitals. And we've been able to get some meaningful data that says this network is helping you be sustainable into the future. Now, the reimbursement question is the gorilla in the room. So, the takeaway from here is, how do we get the meaningful health data to back up what we've put into action so that we can get reimbursement models that are different, that are innovative, that supply that funding to help us move this into the future? Because, let's be honest, the Big Beautiful Bill Act, with those cuts coming in 29, 30% of rural hospitals will not be here if we don't innovate and do something different. For me, the excitement is we're already doing that. We were ahead of the curve, and we're excited to bring this forward and put Georgia in a light where rural hospitals are not only sustainable, but we're helping to drive improved health outcomes across the state.
Dr. Lyon?
Yeah, I think it's very similar to what Michael said. I mean, digital health has the ability to blur lines: inpatient, outpatient, home, rural, urban. It can blur lines, but you think about if we live in a city, we feel connected. We have our smartwatches, we have our technology that we can help take care of ourselves. You also have the ability to have remote patient monitoring and care in your home and those kind of things. When you move to a rural environment, it's not about convenience. That access is not about convenience. It's about really changing healthcare. So as we move forward, I'd love to see more policy oriented towards systems of care that really support the patients in the rural environment to give them the same ability to impact their own healthcare as the rest of us have that live in cities.
Dr. Freeman?
I love the ideas model blocks out there, right? This is a great idea, but we're going to need many more great ideas to solve the rural healthcare problem, which unfortunately I think is going to get worse before it gets better. So we need everybody in this room, anybody who's a clinician, anybody who's involved in healthcare, to think of other innovative ideas to fix this problem, because it's not going to go away and it's probably going to get worse before it gets better.
And I will include myself on this, and I'll end with a little fun story. There are good people out there that are committed to funding this through philanthropy. And I had the privilege to meet one of those in December of 2025. His name is Tom Golisano. And his $50 million gift to Wellstar is why we renamed the hospital, Children's Hospital, the Wellstar Golisano Children's Hospital of Georgia. When I sat with him in his home in Naples, Florida, he said, I believe in what you all are doing to expand access to rural Georgia, and I want to be part of that. And here's my commitment to you. Literally 34 minutes. That's how that went down. And so we like to tell our story because there may be some of you in here that have $50 million.
Raise your hand.
But yeah, raise your hand and give me your business cards. But tell the story when you have a model. Be vocal about it, because there are people out there that want to help, that have a sense of obligation like we have to provide access to care to everyone regardless of their ability to pay. Thank you. Thank you for being with us today.